trying being
luck, bro.
Oh my goodness, I really
I told you,
underestimated.
right? I can say like that's the reason why actually you guys realize my voice is a bit different at the moment, and because the stress is just also piling up on me as well, and yeah, it's really gonna push you to the extremes. There's going to be a lot of uncertainties, and I bet
That
you're
is
already
true.
facing with that already at the moment.
Absolutely. I think
Yeah.
it's you. I think it's a lot more harder for you, especially because you have a family and two kids. And it's just I can imagine because right now I'm also stressing about my renovation, and I'm not married yet. I don't have kids yet, and I can only imagine what you're going through. But I think it also helps that you and I have each other to sort of like help, like whatever I'm going through. There's areas you can help me with. There's not many areas I can help you with, but I think just knowing that we're in each other's corner does allow the process to be a bit much more bearable.
Yeah, man. All right. So I think it's been a while since we did like a rehab related or
Yes.
related topic. So I thought, right, since I do this a lot now, might as well talk about it. It's a good way for me to also refresh my memory, read up on new things as well, any emerging evidence there is about this. So if you guys are wondering what I was going to talk about today is I'm going to talk about PRP. So for those who don't know what PRP means, that is platelet rich plasma. Okay, so PRP has been around for many, many years. All right, and I'm talking about as early as the 1970s, we already had evidence of PRP being around. And to just summarize what PRP is, it comes from platelets and is suspended in plasma. Now, if you look at your blood, of course, it looks red when you just draw it out. But when you actually centrifuge it, this blood actually divides into 3 distinct layers. Possibly you can say it as 4 as well. Okay, so the most obvious layers are going to be the top. I probably will get our production crew to put it in the picture. All right, you'll see the top plasma layer and the bottom blood layer. Those are the 2 very distinct layers that you'll see. But there's this thing called the buffy coat that sits right in the center. So that particular buffy coat contains 2 things. It contains white blood cells and it contains platelets. So for those who don't know what platelets are the thing that clots your blood when you get like a wound, a small wound that you get. The thing that goes and stops it from bleeding further is the platelets. They create the scaffolding that stops the bleeding from progressing. And this happens anywhere and everywhere in the body. And it's one of the reasons why people get heart attacks as well. So when you get vessel injuries, internal injuries, say from chronic smoking, not really high cholesterol, but the effects of the inflammatory markers that builds up because of high LDL, it causes internal scarring within the vessel. And when that scarring gets a bit too bad, it starts bleeding a little bit in there. And then the platelet tries to stop the bleeding in a vessel that's already small. So imagine something building as a scaffolding within a vessel, eventually blocks the vessel. It forms what is known as a thrombus. And that thrombus, if it goes down to a smaller vessel, so it could be from a big vessel, high blood pressure, it dislodges and goes down to a smaller vessel and blocks it completely.
Correct.
And that particular part of the area can die off. And that's how you get a heart attack or a stroke and so on and so forth.
Yeah.
So it is beneficial, but it also has a problem when it comes to this kind of pathological disorders. But that's not what we're going to talk about today.
So just to recap again, to give the listeners an idea, doctor draws the blood. It goes in those vials. They put it in a centrifuge, which is basically a machine device where it spins
Correct.
at a very fast. How many RPMs do you?
Okay, yeah, we'll talk about that.
Oh, we'll talk about it, okay.
Yes. I'll talk about how we make it as well. So yeah, so platelets are derived from this thing called as megakaryocytes. And as I said earlier, platelets have a very important function in clotting. But in research, we found out that back in the days when this started we realized that it has this thing called as alpha granules in them. So think of it as little pockets that contains growth factors. Okay, so whenever it goes to stop bleeding in a particular area, right? Now, how does that area also go on to heal? So that's where it degranulates these alpha granules and releases growth factors into the area.
Okay.
All right. So these growth factors actually can mediate healing in a particular area.
Okay.
So hence the idea of, can this be used somewhere else as well? Can this be used to heal disorders when it regards to musculoskeletal, hair growth? You're talking about eye issues. We have seen this even used in other urological disorders
Skin?
as well. Yeah, skin as well. All right. Anywhere and everywhere, because platelets ubiquitous, it's everywhere.
As long as the cells, right, present.
As long as there's blood traveling to the area, the platelet will have its function there. Okay? So so the platelets actually have the ability to help regeneration. Okay, so that's why the term regenerative medicine came about. Okay, so we use this kind of treatments to regenerate or heal a particular area, whether it's acute or chronic, depending on when and where you want to use this. Okay, now so the PRP induces production of collagen and growth factors, and might increase even stem cell numbers, which consequently promotes the healing process by delivering high concentrations of alpha granules, which are biologically active moieties.
But just to clarify, PRP and stem cells, two different things, right?
Yes, two different things. Okay, so stem cells are, okay, you want this particular detour to change to a bone, you have to put it in the setting of a bone. So the stem cell has to go to an area of a bone. You want it to change to a cartilage, you got to put it in an area where there's cartilage as well. So stem cells will transform into those areas depending on the protein that particular area triggers for it
Correct.
to change.
Correct.
Okay, so stem cells sits right on the top, and you get your red blood cells, your megakaryocytes, and whatsoever, all the other different bloodlines, and they switch to whatever they need to based on the signals in those areas. Okay, so yes, so technically stem cells are more expensive simply because it's harder to yield.
Correct.
Okay, you got to go into someone's bone marrow to find that.
It's a very painful procedure.
Yeah, so yeah, exactly. All right. So just to talk a little bit about these growth factors, the platelets actually contain a lot of growth factors. I'm not going to talk to you guys about how all of them actually, but just to name a few. So we have this thing called as transforming growth factors, fibroblast growth factors. Like the fibroblast growth factors, right? It has the ability to enhance chondrocyte osteoblast growth. What is chondrocyte? Chondrocyte is what forms your cartilage. For those who don't know what cartilage is, if you are a non-vegetarian, if you eat like drumsticks, right? You kind of break the joint and you'll see this white coat sitting on the end of the joints. So that end of the joints is called as cartilage, or in Malay we call it rawan. Okay? So things like osteoarthritis, for instance, it's a wear and tear issue plus an inflammatory condition as well. So in this wear and tear and issue and inflammatory condition, there is cartilage breakdown. When cartilage breaks down, there's a lot of pain, and then it goes on to form this bone spurs that people talk about in osteoarthritis. So the issue here is either the wear and tear or the inflammation is messing up the cartilage, and then it goes on to mess up the entire cascade that happens inside the knee. That's why it gets swelling and pain and friction and difficulty to move, loss of mobility, and so on and so forth. So the platelets actually contain factors that can actually assist in healing of these chondrocytes. Okay, they also modulate cartilage production via transforming growth factor. So collagen production is very important. So for instance, if I put it in a tendon or ligament, collagen is there. Your tendons and ligaments are formed by collagen. So if it helps collagen proliferate, then of course it helps in the healing of those areas as well. Then you have epidermal growth factors, which also partly helps in collagen production. Then you also have vascular growth factors, which help blood vessels grow. So if, for instance, you're talking about like a hair transplant, okay, and after a hair transplant, sometimes they actually inject PRP into those areas. Why? You want blood to grow into the area. So like someone like me who has a lot of bald spot, likely the blood vessels in the area which is already bald is not great anymore, or is not there, or is dead. Okay.
So your bald is not a choice, right? It's a look. It's not a look. This whole time I thought you actually chose to be bald. It's like
I chose to be bald.
You chose to be bald.
I just didn't pursue the hair growing line of I don't know. I didn't pursue that simply because I was like,
it's not because of creatine, is it?
No, man. Let's not go there.
Okay.
That's a very misinterpreted study. Okay, yeah. So yeah, I'm bald by choice. Okay, I didn't try to grow this back. I'm just too good looking bald.
Actually, you look good better, especially when you have a daughter.
Yeah.
And when she starts dating, you want this look.
Yeah.
Back to the topic.
Back to the topic. So yeah, there's a lot of growth factors in platelet rich plasma. So the entire reasoning behind why we want to use in regenerative medicine is in certain areas in our body and certain conditions, those growth factors don't get to reach those areas. Now let's take the knee for instance.
Yes.
The knee is a joint, a synovial joint. Now in a synovial joint, there's no blood inside there. Okay, a lot of your nutrition that goes to your joint comes to it via diffusion. Okay, so this nutrition or nutrients that your knee needs, your cartilage needs, your ligaments inside your knees need, all are coming through diffusion. there is some blood vessel, but it's not great in those areas. Okay, so what like things that PRP treatment does is it allows us to take it from your blood and deliver it into your knee.
Like a direct.
So that is the idea behind that. And in certain chronic conditions, it is a good way to restart healing, because chronic condition is basically an injury that has maladapted. Okay, and how do you pull it back to its healing ways? Is you probably have to restart the injury. Of course, you can't go and tear the ligament or tear the tendon again, but we can biochemically start back this particular healing process. So that was the idea behind why we use PRP. Okay, now we've spoken about what PRP is and what it contains. Now let's talk about the types of PRP that we have. Now, the two easiest way to divide PRP is either whether it's WBC rich or WBC poor. So if we backtrack to what I told earlier, in that Buffy coat, there's two layers. There's the platelet and there's the white blood cells that sits on it. So for those of you guys who don't know what white blood cells are, that's literally your army that actually fights infection and those kind of things. Okay? So those white blood cells, when you centrifuge it, they kind of stick to each other to the platelet. So it's not that easy to separate them out, though they do have different weightage or molecular weightage. If you know how to centrifuge it, you might even be able to separate that as well. Okay? Now, majority of the platelet for the types we have in the market right now are mostly WBC rich. Okay? Because getting it to be WBC poor is not so easy. Okay? It's a bit more technical for them to get it to become WBC poor. So there are companies that already have the kits that can make it WBC poor, but it also is more costly. Okay? Now, the difference between WBC rich and WBC poor is more likely to the reaction that you get after the injection. So inflammation is mediated by your white blood cells as well. So when you have a PRP that contains high amounts of WBC, the post-injection reaction can be a bit more, not extreme, but a bit more actually.
Yep.
So that can cause a bit of post-injection pain and sometimes mild swelling as well, which is self-limiting.
Okay.
Okay, majority of patients who go through the injections with WBC rich are going to experience about 3 to 5 days of pain, maybe up to 7 days of pain post-injection. So if you're wondering why after PRP it hurts so much, it's because of that. Now, when you use the WBC poor PRP, or in some places we call it as platelet rich growth factors, all right, the inflammation post-injection is a lot lesser. It's not completely no WBC. There is some still, but just a lot lesser. So the post-injection pain is much more bearable and it's a lot short-lived.
Yeah.
Okay, so especially like a big joint like your knee, right?
Correct.
If your knee starts hurting, then it's going to be tough for you to walk and function because of that pain. So for that particular reason, patients who can afford it, I would advise them to go with WBC poor. Patients who have very poor pain tolerance, I would advise them to go with WBC poor. Okay, now when you talked about the centrifuge earlier, the speed of centrifugation depends on what we want to produce. Most of the WBC poor or platelet-rich growth factors requires what is known as a soft spin. Okay, so that's between 1,000 to 1,500 RPMs to get that particular PRGF. Okay, they soft spin it. They spin it between 8 to 12 minutes, depending on what we get after we spin for 8 minutes. Most of the time, the ones the company I work with, they prepare it for about 8 minutes. They might have to extend another 4 minutes depending on how the separation happens at the end of 8 minutes. If they're not satisfied with the product that they have gotten after 8 minutes, they might go in for another second spin. Okay? Now, when you are talking about the PRP itself, right, there are PRP with low concentrations and PRP with high concentrations of platelet. Now, on average, most PRP production will have anywhere between 3 to 5 times the number of platelets. Okay? And there are companies that can go up to as high as 9 times the number of platelets that you have. On average, you have about 150 to 400,000 platelets per, if I'm not mistaken, microliter. Okay? So you're talking about 9 times the concentration as well.
Okay.
Now, PRP concentrations like PRGF, they're about 2 to 3 times the concentration only.
Okay.
Now, the makers of PRGF believe that when the concentrations of the platelet is too high, it can be counterproductive to healing because there's too much inflammation it causes.
Okay.
Okay? But on the other hand, we also have studies that shows that on the contrary, when we actually have higher concentration of platelets, we have higher amount of inflammation, yes, but we also have higher amount of growth factors coming through it. So that sheer amount of growth factors can override the inflammation that happens and give it its anti-inflammatory properties. Okay, so there is a back and forth with which one is better. Okay, because different companies are producing different things.
In your personal experience, in what scenario or case would it warrant someone to have the high concentration versus the low concentration?
Okay, so majority of my tendon ligament injuries, I would favor the higher concentration. Okay, for joint injection,
You're already not walking mine as well, right? Well, just go lah. We're not going to walk right after this.
for joint injections, I actually advocate for the usage of the 2 to 3 times concentration. But as I said, it's costlier. You're talking about almost a 900 ringgit increment in the price itself. Okay, to get that particular kit and product.
Okay, so if that's the case, then what? Obviously, there's a difference, but what about the recovery time and all these things? Is it the difference?
Correct, there is. So as I said earlier, the amount of pain you get after the PRGF is a lot short-lived. Some patients, as early as 2 days, they actually feel fine already. Okay, but the ones who use PRP can go up to about 5 to 7 days. So there is a bit of delay in that. Okay, that means before you can actually feel comfortable, it's already a couple more days longer. And the thing is, after PRP injections, you're not allowed to ice the knee or take any anti-inflammatory medication. So imagine if you're in a job where you have to walk around a lot. Okay, you're on construction line, for instance. Okay, you can't take 5 days off. So what happens is, if you take something which is a high WBC count and high platelet count, chances are you're going to have more aches and pains. And if you're in a job where you have to walk up and down scaffoldings and go up and down staircases, it is not going to be pretty. Okay, but nonetheless, when I have done treatments, especially for the knee and the ankles, when I use WBC rich with high concentration of PRP or WBC poor as well, the outcome was actually pretty good for both. Okay, just as I said, there's a little lag of time with the WBC rich simply because of the pain. But at the end of about 6 to 8 weeks, they get almost similar result. WBC poor is a bit better, maybe about 15-20% better. And the WBC rich one is about there. It's not too bad. It's not too bad. They actually do well as well. And at the end of 3 months, they probably come up to about less than 10% difference.
And this is after one injection?
One injection. Okay. So, yeah. So, those are the types of PRP you have. Now, where can we use PRP? I'm a sports physician, so I'm not going to talk about hair growth clearly. All right. Okay. But as I said, PRP has been used for a lot of things, but my specialty is musculoskeletal. So I will talk a little bit about my experience or what I've used and where is the current research with this. Okay, so you can use it in joints, as I said earlier, or tendons and ligament. Now, for joints, in knee osteoarthritis is probably one of the biggest things we talk about when it comes to PRP usage. Okay, so in knee osteoarthritis, mild to moderate knee osteoarthritis, we see very good evidence that it actually works well when you combine it with hyaluronic acid. PRP alone is good, but PRP plus hyaluronic acid, especially high molecular weight hyaluronic acid, seems to work really well. And I have a lot of patients who I've done the injections for, and they do really well. Now, the catch here is a lot of people do the injection and walk out without a rehab protocol. Okay? That's where I think it goes wrong. That's why you get a subpar result. Because there's no guidance of what do I do next. Okay? So for me, that is very, very important. And through my experience, I've realized that part is actually very, very important as well. And I normally guide my patients for the first 8 weeks with the rehab program. If they have a PT or whatsoever, then we get the PT involved. Okay, because it's not so difficult. It's basically a regression of exercise. So you just regress certain exercises, remove certain exercises, add on certain exercises, work on particular things so that we don't aggravate the knee while the treatment is going on. Especially the first 2 weeks is very sensitive. You don't want to push the patient at that point, and they end up getting a lot of knee pain after that. So I want to minimize that while they are recovering from the injection and to get the best out of the knee by the end of 8 weeks. So I've treated patients right up to grade 3 of knee osteoarthritis. Of course, when you're already at grade 3, there's quite a bit of cartilage injuries.
Yeah.
And these are patients who do not want to do surgery. Okay? So I definitely have caveated that, of course, PRP has its limitations. Okay, because you are inducing your body's own ability to heal something. Okay, so how much you can heal depends on how many potholes you have to cover up. Okay, so the more damage you have, the less likely it's going to work. And the earlier you come to me for treatment, the better it is going to be. All right, so some people delay to 6 months to a year, and then expect it to heal in 2 weeks. I'm sorry, that's not how it works.
No.
Okay, and surgery is of course far more costly. So on average, the price of surgery is about 10 times more the price of PRP injection.
Yeah.
Okay, so a lot of younger individuals, so like people like you and me, right? We're in our 30s as well. I'm almost 40 years old. I'm not going to go for a surgery, okay, unless it's really required.
Yeah.
So I'm going to try invasive methods, but not so, number one, costly and time consuming, and plus it involves anesthesia and all these things, right? And of course, cutting into your skin and so on. So I would try something that is, in this case, less invasive. Okay, just a needle going into your knee, and it's not so painful. 30 minutes, you're done, and you're out of that. And then you go through a short rehab process, and then your knee starts working better. So I would give that a try, maybe 2 times a try. Okay, I've done PRP multiple times. Okay, not for my knee, but I've done it for my muscles, my ligaments, my tendons. Okay, so for the knee osteoarthritis, as I said, mild to moderate, pretty effective. Do it right. Make sure you go through a rehab protocol. There are do's and don'ts to the injection. I'll talk a little bit about people who are not suitable for it at the end of this talk. Okay. Now, for the next condition that we normally use it for, which is a lot of what I see as well, is rotator cuff tendinopathy. Now, rotator cuff tendinopathy we're talking about is the supraspinatus in your shoulder. So when you have small tears, when you have inflammatory, like subacromial subdeltoid bursa inflammation, or even just rotator cuff tendinopathies, PRP injections are actually quite helpful, especially when it's chronic tendinopathy. So what is chronicity is anywhere within, we're talking about roughly about 6 to 8 weeks after you have the condition, and the pain is still not going away. So we already passed acute inflammation. And trust me, most patients don't come to me at 6 to 8 weeks. They come to me after 6 months of trying everything. And then, of course, there's already a lot of changes that's happened to the tendon at that point. We're not just talking about rotator cuff tendinopathy. You're probably also having a maladapted scapular motion. Scapular dyskinesia is already set in at this point. So there's more things to mess with. Okay, the scapula is probably winging at this point, and that itself is not letting the rotator cuff heal. So what I do normally is I try to address the scapular motion either with the physio or the personal trainer itself to get them to work to improve the scapular motion first. Because if the scapula, especially the acromion, is going to keep irritating the supraspinatus is not going to heal. Okay, so I get them to address that through exercise, proper exercises, and patient has been committed. Okay, then after a while when I see that scapular motion is a bit better, then we go on to do the injections. And the difference between doing a tendon-related injection and a joint injection is a tendon-related injection, you have to go into the tendon. So if you're talking about discomfort of an injection, tendon injections are more uncomfortable, okay? Because I need to literally marinate the tendon with your PRP. Okay, so that requires me to fenestrate the tendon while doing it. It takes roughly about a minute to do it. Mm-hmm. Okay, but that minute will be very long for you if you're the one going through the process. So after that period, you get again about 2 weeks period of relative resting, followed by gradual physiotherapy to get the tendon back to strength. Okay, likewise for the bicep tendon as well. And in research, we see that patients who use PRP actually do far better at about 2 months and above. The immediate difference between PRP injections and like corticosteroid injections, corticosteroid is going to win the race initially. Okay, it starts off really fast, but it wears out really fast too. Okay, and you have to understand corticosteroid is anti-inflammatory, but it's not regenerative. Okay, so you have to know where and when to use corticosteroids, which I used to, but it really depends on where I want to use it, for who I want to use it, the age, the person's level of activity before I use things like corticosteroids. I do not do corticosteroids into tendons, though in the past we used to use it in around the tendons. I don't do that anymore because corticosteroids can be actually detrimental to tendons. Okay, and if you do it frequent enough, it can cause tendons to rupture. Okay, so I am for PRP injection, especially in the active population. But things like bursitis is a different story. Tendon sheath swelling is a different story. There you can use steroid for that. But if you're talking about the tendon itself, you don't see swelling, but there's pain in that, and there's a lot of dysfunction in the tendon, then for me, PRP works a little better. Okay? So that's something that we can use as well. And in research, you see that they actually do better with PRP than not doing anything at all. And this is normally done in people who have exhausted physical therapy. They've tried physical therapy for 6 to 8 weeks, sometimes 3 months. They're not seeing much improvement. Then we got to escalate it up a little bit. That's where PRP comes in. Okay? Let's talk about things like tennis elbow. Yeah, tennis elbow is really good. I like tennis elbow. A lot of people who have suffered long-term tennis elbows, they actually react to PRP really well.
Okay.
Okay. Like literally after the procedure, the guy couldn't move his hands. But 2 days later, he's like, doctor, I feel a lot better right now. And then by the end of 2 weeks, he's like, my hand is starting to function. Like, the pain is a lot lesser. And by the end of like 6 weeks, the guy is already ready to play pickleball again. But as I said, the goal or the secret here is not just the PRP, it's the rehab. I can give you all the raw material you need, but if you have no blueprint to how to fix this particular area, you're not fixing anything. That brick is going to stay there.
Correct.
Okay? So that is where rehab comes in. Okay? When you do rehab exercises, when you tension those tendons and ligaments, the signals that come from that, okay, is what aids in the recovery, and it uses the PRP as your care package to heal the entire thing. Okay? So that is the idea behind combining PRP injection with rehab. Okay? So a lot of people who see failure after PRP, if you ask me, the protocol after the injection was a problem. And I've asked multiple patients who have tried PRP and it failed simply because there was no post-injection care. Okay, I come up with an entire set of instructions that you have to follow after I give the injection. Before and after, I have very specific things that you have to do. And for that reason, my success rate is quite decent. Talking about 85% and above. Okay, there are, but they're very, very few. Okay, and those are the cases where they're literally refractory already. Means nothing has worked. We gave a shot. And patients are very well aware of that. When we give it a shot, it may or may not work. We will see how it goes. Okay? So, yeah, so in tennis elbow is very helpful. Patella tendinopathy, especially if conservative methods have failed, I have done PRP injections for patella tendinopathy. I've done one in a kid that has sliding Larsen-Johansson disease. Basically, it's a patella tendinopathy that happens in a very young individual, less than 15 years old. So what happens is it actually affects the patella growth itself because it can avulse the bone. So this kid came to me with 3 years history of sliding Larsen-Johansson disease. And at the point when he saw me, he barely could walk up staircases. He's already back to squatting, and I just started his plyometric protocol after 3 months post-injection. Single time of injection, and then very, very strict protocol to follow after the injection. The kid has been following the protocol really well. So right now we just started plyometrics. I'm keeping my fingers crossed. 3 years of pain, you come to me, and in 3 months you're starting to reverse. That's for me a big success already.
Yeah, or at least you resulted from excessive training or activity.
Most of the time is not strength training.
What about your experience with regards to weightlifters?
Actually, weightlifters not as much as well, because as much as they do explosive motion, but most of the explosive motions are probably within the 1 to 10 reps. Okay, unless, if they do like panda pulls and so on, probably do a couple more. The whole sport is literally built around jumping. Same like volleyball, how not to jump. Badminton, how not to jump.
Yep.
Okay, you better not play the sport. Yeah, so the jump is built into the sport itself. So that's why the risk is higher. I do see it sometimes in runners as well, but it's not as often. Another thing I want to touch on the knee as well. It's not just arthritis that actually treated with. Some patients also have this condition called chondromalacia patellae, basically softening of the cartilage. So I see this in younger individuals. I'm talking about people in their 20s and 30s coming in with severe anterior knee pain, behind the kneecap especially, and a lot in the pickle pedal players and runners. And I'm talking about as early as 6 weeks, the patient do really well. Okay, and the longest I had to rehab someone was 10 weeks. So most of the time, within 6 to 8 weeks, the knee starts doing really well. They go back to the activities, and I progressively ask them to reintroduce running. So I give them a return to running program as well, and then eventually they go back. A few of them who already started running marathons as well. Okay, now what are the contraindications when you should not be doing PRP injections? Okay, so yes, PRP has a lot of benefits, but there are times when it's not going to be suitable. Okay, now in elderly individuals, at least above 60 years old, most of them do have some comorbids. So the quality of the PRP becomes a bit questionable. So contraindication, I say elderly individuals are a bit tricky, because once you pass the 60-year-old benchmark, if they have comorbidities, the quality of their PRP is going to be quite questionable. On top of that, if they are taking medications like aspirin and like clopidogrel or blood thinners, for instance, right, then it's a no-go immediately. because aspirin is a platelet killer. Okay, so the platelet is not going to function. So if they're on aspirin, immediately is a no-go. Okay, clopidogrel as well. Once they're on it, it's a no-go as well. Okay, if the patient is anemic, okay, then the quality of the PRP can be a bit questionable. But if they have very mild anemia, you still can consider. We normally have a double spin to get a bit more platelets. But I have done it in anemic patients as well, but it has to be mild anemia. Okay, if it's like one of those where your anemia is like you got a 9 grams per deciliter of hemoglobin, then I'll probably say don't try PRP. Okay, because likely not just their red blood cells affected, their platelet function is also affected as well.
Yeah.
Okay, now if someone has an active cancer going on, I would not recommend PRP injection. If you can regenerate your knee, you can regenerate your cancer cells as well. So I would never advise for PRP injections for someone who's going ongoing active cancer. Okay. Blood disorders besides anemia is thrombocytopenia. Thrombocytopenia means the lack of platelets. So there is a condition called as idiopathic thrombocytopenic purpura, mostly seen in boys. So if you do have that genetic condition, then PRP is not suitable for you as well. So that's another thing. And other clotting disorders like von Willebrand disease as well. So this one all affects the platelet function. So that means the platelet is either poorly shaped, not functioning well, or the lack of it just by sheer volume. All right. So that's not a good one. Infection. If you are actively going through an infection, especially like when I'm about to do PRP injections, I actually send out a note to my patient. If you had fever or flu in the last 1 week, we have to postpone it. Because what happens is your white blood cells actually go up really high. So when that happens is we will yield more white blood cells with the platelets, making the injection more painful as well. So most of the time I just say let's delay it another 2 weeks and then we do it after that. Okay. So I do tell patients when I'm planning for their PRP injection, please do take care of yourself prior to the injection, because if you do get a flu or fever, I have to postpone it. I won't even might have to. I will postpone it immediately, because if you're going to pay about 3 to 4 grand for an injection, you might as well get it right.
Yeah.
Okay. So I don't want to waste money and waste time at this point. Okay. So yeah, if you're in an active state of infection, and if the place has an infection, so you want to do it in your shoulder and you have a wound there, we're not doing that injection in that area, because you just might transmit whatever infection from outside into the area you injected. So we don't want to do that as well. Any autoimmune conditions like serum sickness, okay, you don't want to do PRP injections. But in certain cases like rheumatoid arthritis, there has been evidence that PRP can be helpful. But as for me, I'm yet to do it for someone who has an autoimmune disorder that's affecting their joints or tendons or ligaments. Okay, because I'm not quite sold yet with the usage of PRP in those conditions, because it is still coming from your blood, and if you have an autoimmune disorder going on, could it affect the quality of the PRP? I think it can. Okay, so I'm a bit wary with that, so I don't do it as well. And last but not least, cardiac condition, unstable angina. So as I told you earlier, platelets can also cause blood clots to form, which can cause heart attacks. So in patients who have unstable angina, they are more likely to form thrombosis, which actually can lead up to a heart attack. So it's definitely, if you have a case of unstable angina, which is heart pain, I would also advise not to do PRP injection. So these are the contraindications for it. Now, is there a downside to PRP injections? Of course there is. With any treatment there is.
Yeah,
Number one, your pocket is going to go a bit lighter. Okay?
Major downside.
Yeah. So on average, PRP injections can cost, if people are doing it at the back of their clinic, they're probably going to cost you like $400. Okay, but those who are using proper kits, all right, it can cost you north of 750 ringgit all the way up to about 2,000 ringgit, depending on the type of PRP you're using. This is excluding the procedure price. Okay, so it is not cheap. All right, so if you want to do it, you got to consider whether you have the financial backing for that. And most insurance do not cover PRP injections. Okay, multiple patients have tried to claim PRP, they'll kick it out immediately. Then the other thing is the post-injection pain. As I told you earlier, there is a lot of discomfort. Maybe the first couple of days. It gets better as the day goes. And if you have poor pain tolerance, this might not be comfortable, especially like for joint injections. Ligament and tendons, they are a bit more tolerable. Within like first 3 days, it starts getting a lot better. Like when I did my shoulder, I think like the first 2 days was painful. I was already able to move my shoulder pretty well by the third day, and by the fifth day, I had full range of motion already. There is a possibility that you will need more than one treatment. So in my experience, in probably the few hundreds I've done so far with this current clinic of mine, I only had to repeat it 3 times for the second injection. So it's very rare. And two of it is because patient didn't listen to my rehab protocol. It recurred too early. So I had to do it again and get them on the rehab protocol this time to listen to me properly. And the second time it worked. So yeah, that's one thing. Yeah, and then the other thing is if someone is doing it non-guided, so the efficacy of the injection can be not a bit variable. Okay, that means guided means I'm looking where I'm injecting. Okay, so the efficacy is really dependent also on the person who's injecting as well. So the technique is very important as
Correct.
well. So besides that, nothing really major will happen.
I think more than anything also, like you mentioned, the downsides is obviously it's costly. It is effective, but it's costly. And where you get it done is important. But I think more so than anything, who you get it done with is also just as important, if not the most important aspect. Because I know there are a lot of experienced and qualified doctors that do it at proper places, especially hospitals that do it guided, they do the proper injection, they use all the right tools. But if you're say an athlete, seeing a doctor who is also an athlete himself can definitely help the whole process. For example, if you say you're treating a powerlifter, it would make more sense if you go to see a doctor who himself is doing who's doing powerlifting. The reason I say this is because some doctors out there who are say not doing any sports currently, maybe they did in the past, it would be difficult for them to relate to the patient if the patient says like, okay, doc, currently this is my program, this is my cycle, or how soon can I get back to so and so. Some doctors, although they are empathetic to a certain degree, they just do not understand the extent of how important is it for, say, a junior who is in his last year of competing to get back to training to achieve these particular records. So I think that's why seeing a doctor like yourself is critical in that area, because you understand the importance. You are the chief medical director of the federation. You understand, you see these kids all the time, and it's important in that regard. So seeing a doctor who knows the sport, I'm not saying Arvin, but if you had an opportunity to see a doctor whose background is also very much close to the sport which you're doing, who does the sport you're doing, is going to help the process so much better, because he can use the jargons, that you can use the terminologies that you use,
Yeah. I mean that's true. One of the things that I make sure that I speak with the patient is timelines.
Yes.
So if I need 8 weeks from you, and you say you have to travel to Japan in a week's time, then I'm going to say that's not an appropriate timeline for us to do this injection. So if the patient can't commit to the rehab, as I said, after the injection, I'm going to be very wary about doing the injection, because the effectiveness is going to be questionable. Okay, so the timeline is very important. As you correctly said, I treat a lot of athletes. I treat a lot of people who recreationally compete, especially like high rocks, red line, all these things. I also understand the demands of the sport. So when we're going to do this trip, I've done treatment for people who are about to say do high rocks in May. They come to me either December or January. So they're like, can I compete in high rocks by then? So considering that timeline is possible. But I say you have to strictly follow the rehab, and we have to do it like notch by notch. You got to hit every marker that has to be there in order for me to tell you you're going to be able to do it.
Yeah.
And I'm also going to be able to guide them, because like high rocks, I know what the event is about. So I can tell you, okay, I think this time I can already clear you maybe for a sled push. Maybe not a wall ball just yet. Okay, or so on and so forth, or ski ergs and those kind of things. So that with that knowledge, I think it's easier to communicate to them how we can get to the end, or how do we get to the end of recovery and get you back to training with this timeline in place. So it's very, very important. And some questions that people ask me, like, after doing injections, that why can't I do upper body movements? I said, because when you do upper body, like you do a row, for instance, right? Your leg has to be against the platform. You need to push back against your body so that you don't move forward too much. All right, so that itself can irritate the knee.
Actually, I am going to see Dr. Arvin for my bicep. I have a bicep tear.
Yeah.
So he's going to inject my bicep tendon.
So based on who I'm treating, when I'm treating, I will give them those specific information when the time comes.
Correct.
So yeah, in a gist, PRP has been very helpful when it comes to treating conditions that are, number one, chronic, and it has given hope to people to actually delay operations, especially when you are maybe too young for an operation, or you're just not ready for one. PRP seems to be a middle ground right now, but knowing when and where to use PRP is very, very important. It should not be a trigger-happy treatment.
Correct.
Just everything and anything you want a PRP. I've got a really weird request before. Okay, So I do every case, I take it a case on case basis, and I discuss with patient the options first and what are the outcomes we expect from it. And when it's clearly not suitable for them, I will say it's a no-go. At least I don't believe that it's going to help you, and I don't think there's any point for you to waste your money on it. So whoever you go and get your PRP treatment from, make sure they explain to you properly. Ask as much question as you need to for you to understand what you need to do before you get those injections, so that we are very clear of the outcomes we expect from it. All right? So that's it for today.
Awesome. Very
Alright.
insightful episode on PRP. If you guys want to have more questions, obviously we have an Instagram. Drop us a question. If you want to see Dr. Arvin at his clinic, Dr. Triton's clinic, drop him a text as well.